Good afternoon, everyone. Participants here, good afternoon. Yes, thank you for joining us and so early. We are set to start in the next 1 minute. So kindly introduce yourself as is our custom in the chat, and so that we can know and meet you. Thank you. Introduce yourself, and we'll start now. Really, our panelists are here, and we're excited to get into it. And we have a lot to discuss today, so to be great to start on time so we can finish early. Yes, welcome again to another session of fireside chats, is what we call it at NSSF. So this is the first of the 2024 series of the fireside chats. So just welcoming you again. I want you to participate. This is really for you. And so that you give our panelists a reason to come back on this platform. So we want your active engagement. Part of the rules of our series is that if you have questions, you put it in the Q&A box, and you don't have to wait for the question session, so we can take all of them when we get to the question sessions. During the panel session, please comment on your thoughts and your opinions and on the conversation ongoing, even during the presentation. So we'll be glad to have active participants. We want the action in the chat room. So please make good use of it. And if you want to also ask questions, you can raise your hands during the questions session and we can unmute you to ask questions. Great. So we get started. I am Dr. Fejiro Chinwoko. I'm the CEO and MD of Nigeria Solidarity Support Fund. And I'm your host today. It's my privilege to host you today to this event. I'll be starting off with introduction on what we are here for today, and then I would introduce our anchor for today, who is here with a lot of energy and excited to take us through today. This is our first, like I said, of 2024 Fireside Chat series, which is titled Innovating for Healthcare in Nigeria. It is hosted by the Nigeria Solidarity Support Fund. We're an NGO ensuring that all children are safely immunized in Nigeria. And we're also holding our health policymakers accountable to this goal. One of the objectives of our Fireside Chat series, we have three main objectives, and the first for this series is to make sure that we facilitate discussion between the public, our attendees, our participants, and our policymakers. And so that's why I emphasize that we make good use of the chat room and communicate and have the banter, which would increase our knowledge gained at the end of the day. Second is that we'll be sharing knowledge on innovations and focused on AI and tech advancements in healthcare to promote healthcare service delivery in Nigeria. And thirdly is that we would highlight obstacles in the healthcare system in Africa, and we would attempt to prefer innovations and solutions that can tackle these obstacles. At the end of the day, we hope that we would have held our health leaders accountable, all of us including NSSF and our participants, would align our stakeholders in vaccine space and in the health space to a forward-thinking approach to scale vaccine uptake in Nigeria. We would have shared expanded solutions, and then hopefully all of this will lead to an improved primary health service. Here in the room today is a diverse mix of policymakers, healthcare workers, health advocates, civil society organization, and implementing partners, donor agencies. So it's a diverse mix, and we're glad to have that mix in the room. The first part series today is titled Using AI, Artificial Intelligence, and Tech to Drive Vaccine Uptake. And I'm sure you're curious to know how this is possible in Nigeria, seeing where we are technology-wise. But yeah, that's why we're here today. We know that digital technologies can transform healthcare as it has transformed every other sector of the globe, of the world. And we know that this transformation can improve accessibility to health services, can ensure that we have more effective health service delivery, and then most especially is that we have patient-centered care and our patients are satisfied at the end of the day. AI is used globally in the world now to revolutionize all industry, and we definitely don't want health to be the last to catch up, especially vaccines in Nigeria. We know that vaccines is the most impactful and cost-effective public health intervention known to prevent mortality and to reduce mobility. And that's why NSS is very interested in making sure that all children in Nigeria get vaccinated. Currently, there are less than 10 African manufacturers of vaccines. And so, and that means that we are not even in that place. But of course, AI can lead up to can aid that conversation, vaccine production, making sure that vaccine is accessible and making sure that it is also given in a safe and effective manner. We want to increase our vaccine uptake in Nigeria. Recently, we're at 50% of using the DPT3, and the African target is at 80%. So we want to get to 80%. So there is a gap, and moving forward, we are ensuring that we close that gap. Of course, working with all other stakeholders involved in the vaccine space. So that's why we are here today. It's my privilege to having introduced this session on why we're here and what we'll be discussing, to introduce our anchor for today. Our moderator for today is Dr. Ayodele Rena, as a consultant pediatrician, one of Nigeria's most influential child health advocate. He's an online content creator and an influencer. He's the co-founder of Agnosis Care on Demand, a digital healthcare platform that creates tech-based solutions, including an AI-driven platform for healthcare professionals to host communities of their clients, provide convenient vaccination services to children and adults in the comfort of their homes, and offers subscription-based online primary healthcare services for children. So you can see the reason why we have him here today. Monthly, Dr. Reynard reaches between 500,000 to 2 million people on his Instagram page. He's known as the noisy Nigerian pediatrician with free public health education. He has helped thousands of parents and caregivers make better and more informed healthcare decisions for their children. His style of health education combines evidence on the best global practices and a keen knowledge of local child care practices with humorous anecdotes and sketches. This has endeared him to numerous parents in Nigeria and outside of Nigeria. His work in promoting better child care through public enlightenment and health education has been recognized with 2 nominations from Healthcare Influencers of the Year. He volunteers for NGOs like Ask the Pediatrician and Olivia Health to provide medical services and relief to children in disadvantaged areas. He has made numerous TV and radio appearances, including TVC, BBC Radio, and Rave TV. He has been spotted by Gavi for his work in the digital healthcare space to help improve child survival in Nigeria. Dr. Ayodele Rena, thank you for joining us today, and over to you.
Thank you very much, Dr. Chinyemoko, MD CEO of NSSF, the Nigeria Solidarity Support Fund. Very kind words there. So a very warm welcome to each and every single one of us here. We are here to discuss how artificial intelligence and tech can revolutionize and revamp the healthcare space in Africa, especially as it relates to vaccines. Because as Dr. Kuchiro has already pointed out, vaccine coverage in Africa, and specifically in Nigeria, can be significantly better. So 50% coverage for DPT, while we're targeting 80%. A lot can be done in that space. And so once again, a very warm welcome to everyone here. I trust that you're going to have a particularly enlightening time because the panelists that we have here are erudites. They are distinguished and they are eminently qualified to have these discussions with us. And so my first task is to introduce our panelists. Just to remind everyone once again, this is a roundtable where we are discussing innovating for healthcare in Africa. And this session, the part one of this session is going to is AI and tech to drive vaccine uptake. Okay, so I will be reading out the citations of our various speakers. Kindly permit me to start with Anna, because Anna was the first person that appeared. So Anna, don't worry, you don't have to stand for this. So Ana Fernandez Del Rio is principal data scientist at Causal Foundry with a background in theoretical physics and statistical physics of complex systems and close to 20 years of experience in data and modeling related research. She has extensive experience with different statistical and machine learning algorithms, focusing primarily on human behavior modeling. She has developed an array of data science solutions throughout her career, both for the industry, Inditex, Coca-Cola, Telefonica, Sharing Plow, and a lot of others, and in organizations with demanding operational setups, including the German Weather Service. During the last 4 years, first at Benshi.ai and now at Causal Foundry, Anna's efforts have focused on reducing health inequalities through data-driven adaptive digital interventions to nudge health workers' behavior and improve patient outcomes. Anna holds a PhD in science modeling of human behavior from the Spanish National University of Distance Education. In addition, she holds an MSc in statistical physics of complex systems from the Spanish National University of Distance Learning and an MSc in theoretical physics from the Autonomous University of Madrid. She has co-authored 10+ peer-reviewed articles and is a frequent speaker at international conferences, workshops, and events. So please kindly join me to warmly welcome Ana Fernandez. So thank you. I mean, I'm sure they're giving you virtual applause. So welcome. So it's a fireside chat, hopefully virtual fires. Let's not light any fires in our homes or in offices. So the next person that I'll be introducing will be Cyril Sek. Now, Cyril Sek is an independent strategy and policy advisor. His expertise covers strategic planning process, organizing, design, and implementation. He has advised governments, foundations, multilateral organizations, and corporations across a wide range of sectors, emphasizing public health in Africa. Cyril, you are very welcome, and thank you for joining us for this session.
Thank you for having me.
So I will be introducing someone that I'm very familiar with, my friend, Dr. Choma Wakama, before I go to my classmates. So Dr. Choma Wakama Akano, also known as Dr. Zobo, she proudly wears the Zobo label as a badge of honor. Now, Dr. Choma Wakama Akano is a reproductive healthcare physician, speaker, and advocate. She is a founder of Medically Speaking Services and creative director of Dr. Zobo, a prominent virtual health literacy and advocacy platform dedicated to improving the health and rights of African women and adolescents through witty visual storytelling. She is the executive director of Smile With Me Foundation, a non-profit organization leveraging digital technology to provide underserved women and adolescents with quality and affordable preventive reproductive healthcare services. Since 2017, her NGO has focused on 4 critical areas: STI and cervical cancer prevention, menstrual hygiene management, contraceptive care, and gender-based violence mitigation and response. She holds certifications in leadership and management in healthcare from the GBVIE from engagement from University of Delaware, USA. Dr. Choma's achievements include being an alumni of the Young African Leaders Initiative, RLC West Africa, a Mandela Washington Fellow, digital influencer for the International Center for Journalism, Knights Fellow. Adding to her laurels, she was honored as the UNDP Geneva Changemaker for SGS Geneva 2021, a two-time healthcare finalist for the Future Award Africa, a 2021 recipient of the Royal African Awards, and listed as one of the most powerful and influential young Nigerians under 40. She is a cohort member of the 2023 Lead Women Africa Program for Women in Tech. These achievements, among many others, affirm her status as a true trailblazer in the field, a guiding light inspiring change and progress in Nigeria's healthcare sector. It is with the greatest pleasure that I welcome you, Choma, to this session, and really well done on all the great work. Fantastic.
Thank you.
So,
Thank you.
I will be introducing somebody that I've known for years, Dr. Lawal Bakare. So, you don't have to stand for this. Just feel free to sit. Okay. So, Dr. Lawal Bakare is, and I know, a dedicated healthcare professional with strong academic research, policy development, and innovation track record at the interplay of technology, the media, and health. With a strategic role during high-profile health security events such as Ebola and COVID-19, Lawal has become a prominent figure within the global health security ecosystem. If you utilize Ebola alert or obtained a COVID pass to Nigeria, you have likely encountered Lawal's contributions. Presently, Lawal is involved in pioneering work at Safety, leveraging digital technology and innovation to enhance safety and security for people on the go. He is active in biosecurity, building capacity for the private sector on how to protect the biotechnology value chain against misuse. Thank you very much, Lawal Bakare, and you are very warmly welcome. And thank you for protecting us from biohazards and threats. Great stuff.
How are you doing, man?
Let me just see. Okay, so thank you very much. So I see that the Honorable Commissioner is here and Dr. Beno Yakubu is here as well. So I'll go ahead and introduce Beno Yakubu and then I'll introduce the Honorable Commissioner of Health of Ekiti State. So the Director General of NAFDAC, in the person of Professor Mugi Adeyeye, unfortunately is unavoidably absent, and so representing her is a director from the National Agency for Food and Drug Administration and Control, NAFDAC, in the person of Beno Yakubu. Thank you very much, sir, for joining us for this session. We really appreciate it, and please send our very warm regards to Professor Adeyeye.
Thank you.
Okay, so last but not least, definitely not least, I'm going to be introducing the Honorable Commissioner of Health of Ekiti State in the person of Dr. Oyebanji Filani, who of course is an alumnus of the best medical school in Nigeria, argue with someone else. So Dr. Oyebanji Filani is a global health leader and managing director who over 17 years has designed. In the year 2020, he was appointed as the Commissioner for Health and Human Services in Ekiti State, Nigeria, where he has successfully increased domestic resources in the state's health sector by over 300%. During his leadership, Ekiti State was recognized as the best performing state in the country for disease surveillance and response. Dr. Filani also served as the technical director of the Basic Healthcare Provision Fund, BHCPF, between 2019 and 2020, where he provided thought leadership, drove implementation, and ensured the program performance indicators were met across the country. He also served as the senior advisor to the immediate past Federal Minister of Health in Nigeria from 2016 to 2019, He led the data and analytical work that enabled the mobilization of an annual $180 million domestic and development part. Dr. Filani has served on several committees, including the Technical Committee of the World Bank/USAID-led Annual Universal Health Coverage Forum, the Advisory Committee for the Strategic Purchasing, the Advisory Committee for the Strategic Purchasing Africa Resource Center, SPARC, and the Advisory Board to develop a global health equity program of action. He currently serves as a member of the Technical Expert Advisory Committee of the Fair Process Financing, UHC, a joint initiative of the Norwegian Institute of Public Health and the World Bank. Recently, Dr. Filani was reappointed as the Commissioner of Health and Human Services in Ekiti, and serves as the chairperson of the Nigeria Health Commissioners Forum, where he guides his colleagues on critical health system reform issues at the subnational level. In addition to his professional achievements, Dr. Filani possesses a Master of Science in Health Economics and Health Policy from the University of Birmingham and a Bachelor of Medicine and Surgery, MBBS, from the College of Medicine at the University of Lagos. Honorable Commissioner, it is my pleasure to welcome you here to this webinar and this session on AI and tech.
Thank you, Dr. Rana. It's a pleasure to be here as well.
Great. So everyone introduced, attendees, once again, it's really great to have you all here, and thank you for coming on time. So the next item on the agenda, now that the panelists have been introduced, is actually going to be the session by Dr. Cyril Sek and Dr. Cyril Sek. And Cyril Sek is going to be discussing digitizing healthcare in Africa, lessons learned from the field. And of course, we know that Cyril Sek is actually from the Africa CDC. And so we're going to be gaining a wealth of experience and a wealth of knowledge in terms of what the Africa CDC is doing by way of harnessing the power of tech to ensure that healthcare outcomes are improved in Africa. So, Cyril Sek, over to you. We look forward to hearing you expound these deep thoughts.
Good afternoon, everyone. I hope you can hear me. Thank you for having me. I'm joining from MWC, the World Mobile Congress in Barcelona. So it's there are more than 100,000 people around me, and it might be a bit noisy. But happy to spend time with you and walk you through to provide you with an overview, the highlights of the strategy we put together at Africa CDC. And maybe before I jump into the slides, I'll start with a few words about Africa CDC, because not everyone may be familiar with this very young institution. So Africa CDC is a specialized agency of the African Union. We're in charge of strengthening ministries of health and national public health institutes in the 55 member states. We've been around since, I believe, 2007. And we're focusing on surveillance, so emergencies, public health emergencies, management, preparedness, but also response, but also, strengthening health systems. And obviously, digital is a key enabler in that. So I only have a few slides, but I thought it was important to share, what we're doing, because it basically has an impact throughout the constituency. Let me see. There we go. So this is just to show you the scope of our work and what makes us specific and special at Africa CDC, because it's a very crowded, space. So we're basically focusing on the health part of the African Union Agenda 2063. We have a very specific strategy within Africa CDC that guides our work in the digital space, that you can find on our website. We also have, thanks to Dr. John, a citizen of Nigeria, but also now Dr. Jean Kaseya, we have a very specific agenda when it comes to taking back the lead from international partners and putting it back in the hands of our continent's leader. So that's what we call the new public health order. And then we obviously, we leverage many good practices and elements from all across the board. So what is very, very specific about us is that we have a clear mandate from the member states, and we have regular touch points with ministers of health, which makes that whenever it comes to implementation or making the links between the various frameworks for, let's say, WHO and the actual reality, then we can align, we can make sure that the right decisions are being taken. This slide will show you a little bit of what we call the principles. That's what you see on the left part. So I won't go through everything, but basically what is extremely important for us is to have the patient-centric lens in everything we do. And when we say that, it means that we're not focusing on institutions, but we're focusing on patients. So, for instance, health data should be transferable, and patients should get it. It should not be housed in hard drives that are not accessible. So that's just a very simple example. Then obviously, digital public goods, digital public infrastructure throughout Africa is critical. We want to make sure that we go beyond the national borders of our countries. Most of our countries, they're way too small in order to get to the critical mass that will help them to deliver when it comes to tech and to digital. So we want to integrate, we want to have interoperability within countries, but also across countries, and share some capabilities. Digital is very much based on the idea of the volume of data. And we need to work together. That's really our mandate. Then reuse and improve, design for scale, etc. I won't go through everything, but those are critical principles when it comes to our strategy. Then on the right part, what you see is our scope of work. So there are many frameworks that can be used. There is one from WHO and ITU that describes the various bricks that together make a digital health system. But this framework on the right is a bit more specific. And there you can see everything that we're working with. So from infrastructure to workforce to leadership, strategy, etc. Yep. So this is a summary of our objectives, what we want to achieve specifically. So first of all, our scope of work is both strengthening member states. That's what you see on the left part of the slide, so that they have more accessibility, more affordability, more qualitative, care, but also making sure that our own business processes within Africa CDC, so the various, programs that we run, the various services that we provide to member states, that they're delivered in a more effective way, in a more transparent way, in a more, in a smarter way. So that's the scope. And then specific objectives would really be around, workforce development, around innovation, around the digitization of the various services in country, but across countries. And also making sure that we have the infrastructure that are necessary. And I've highlighted here on the right part a few specific projects that I will maybe share a few words about. So the first one is the Digital Health Workforce Initiative that very much focuses on clinical and non-clinical staff, making sure that they have the level of expertise that is necessary to deliver leveraging digital. And here, really, the idea is not to keep the existing structures, keep the existing pyramids, but to digitalize work processes. So we're not going to be accelerating the way things are being delivered. We want to disrupt how things are being delivered. And this is a really fundamental element. Specifically, what we do here is to help governments, whether ministries of health and or ministries of ICT, to define their targets. So how many people should they have with what kind of skills? And then make sure that the various NGOs or schools, whether pre-service or during work time, can deliver the kind of trainings that are necessary. So what we do is very much coordination, convening, and technical assistance to ministries. Then the digital innovation and data sandbox is also very critical. So basically a sandbox, for those who may not be familiar with it, it's a place where you can try out and you have different types of individuals meeting each other and getting to know each other, to know what is a challenge for the other stakeholders. And here, what we do basically is to make sure that we have entrepreneurs in the health tech space and regulators, so that together they may understand what should change. And we're launching this initiative in a number of countries so that we can come up with very specific recommendations that could then be scaled up to either the regions or maybe sometimes even the full continent. The digitization of primary healthcare is critical. Primary healthcare centers are, they deliver maybe 80% of the care. And they're a great entry door to digitalization. What is critical here is that we want to make sure that the diversity of apps, solutions, approaches, vertical programs versus horizontal programs, that everything is much more coordinated. So here, the question is very much around governance and leadership. Then the very last, the bottom of the slide on the right part. So the Africa Digital Health Index is an initiative that aims at measuring, assessing the maturity of digital health systems in Africa, country by country, using various frameworks in a joint manner with WHO, with UNICEF, but also Gavi, the Global Fund, and many, many partners. Also the various financial partners that may leverage that data. So here what we do is basically make sure that everyone who is interested in identifying the strengths, but also the weaknesses, and therefore filtering and prioritizing what should be done in a sequenced way, can join in the assessments, and then there is more coordination among partners. So during the next World Health Assembly in Geneva, we will introduce the first round of countries that have been assessed. And then there is Health Connect, which is very much a foundational effort that aims at bringing electricity and connectivity to 100,000 primary healthcare centers and 2 million community health workers. So here, the numbers may seem high because it's by 2030. But once again, here, the objective is to align the many stakeholders that are already active in this space. There is a lot of money available, but it's not being used in a very effective way. So what we want to do is to empower countries to make the sound decisions. And yeah. So I hope I'm not too long, but I just wanted to share this one slide that show the ratio of doctors, medical doctors per capita in various parts of the world. And you can see from that, you see where Africa is, that there is no way we're going to train that many nurses and medical doctors and clinicians. It will take a lot of time. So what we need is to leverage digital to leapfrog and deliver the same services, but in a different way. And that's really the promise of digital. So the entry door on this specific topic for us is really Health Connect Africa, which is, making sure that there is electricity, there is connectivity. Here, what you see is basically the partners we're working with, and HETA, which is a specific program from USAID, is behind. So we're working with them, and we want to make sure that member states can make sound investment choices when it comes to connectivity, but also going beyond, specific sector-centric approach, making sure that once we have, sufficient, once we have a business model that makes sense, then we can across sectors, then we can rapidly invest. I won't go into the detail, but there is a specific project plan with those partners, and we've recruited a number of individuals. It's in the pipe, and we hope to achieve those very ambitious numbers by 2030. Then primary healthcare centers, I shared a few words earlier. Basically here, we have a very strong partner, the Mastercard Foundation, and the Commons Project, which is an NGO that is already delivering, co-sharing the effort with us. We will have a roundtable in a couple of weeks in Addis to make sure that everyone who is interested in this topic, whether because they have a specific solution, or maybe because they're funding, or maybe because they're very much interested by a specific programmatic results, can align. Health workforce capacity, I shared the objectives. Those are the partners. PSI is co-chairing this with us. Here, I took that from the WHO website. WHO has a great tool that is called the Digital Atlas that basically, collects and lists all the various, digital tools that exist, or, pilots or innovations. And what we can see here is that in Africa, there is so much going on. But the issue is that we're having many pilots, but we're not scaling up. So really, we think that there is a case to be made to join forces and establish clear, lists of apps or of various, tools, digital tools that have proven efficient and that should be scaled up. Yeah, so those are the partners here. A lot of, hackathons, connectathons. I mentioned the sandboxes, so we'll have one on compliance, making sure that the regulations that apply to entrepreneurs make sense, and another one that will be really about testing whether it works, or in a more technical way. And the final piece is really around the maturity. So here, what we'll do is basically an annual landscape analysis of the maturity of the 55 countries, making sure that this is very much plugged into the operational planning and the investments from the various donors. So, I mean, through those various projects, what you see, or what you should keep, is that we're trying to, at Africa CDC, to convene, to lead, and to leverage the energy from the various stakeholders. We're not duplicating, and many partners, we have more than 75 very active partners that are helping us delivering this. Let me pause here. Yes, there is the summit in Kigali every year. This year will be the 3rd edition. Where it's a great opportunity for all health tech people to meet and to learn from the latest innovations. Let me pause here, give you the floor, and happy to answer any questions.
Very, very many thanks, Cyril. And thank you. We kept exactly to time. I mean, really appreciate all the insights that she provided, but I've never heard anyone say there's a lot of money available. That was, and my mind was blown. I said, wow, there's a lot of money available. Okay, sign me up. But I think it's very key. I mean, when you actually said that, but it's how the money is actually disbursed and distributed that is very important. And I think the data sandbox is a fantastic idea. So just a reminder to everyone, please put your questions for Cyril in the Q&A box, and we'll be answering them during the Q&A panel session. So thank you very much once again, Cyril. That was really, really insightful. So thank you all. So the next session that we're going to be having is going to be one with the Honorable Commissioner of Health for Ekiti State, Dr. Yebanji Filani. And in this session, we're going to be discussing the achievements of the healthcare sector in Ekiti State and how they have managed to achieve the things which have been quite remarkable as far as the healthcare system is concerned, with regards to immunization and women actually accessing antenatal care and getting even postnatal care. I think some of these statistics are absolutely astounding. However, of course, we do realize that challenges still exist, and hopefully the Honorable Commissioner can give us his insights on what can be done to surmount these odds. Okay, so Honorable Commissioner, you are very welcome once again. I will be projecting my slides. Give me a second, I might have some interference here. Okay. So, okay, Amazing, is my screen visible?
Yes, your screen is visible.
Okay. Oh, thank you very much. All right, great stuff. So, Honorable Commissioner, again for joining us. I think the first slide that I would actually like to speak to would be the rota. Let me see. Yes, so proportion of eligible children in the age group 0 to 11 months vaccinated with rota 1, 2, and 3. So, I mean, clearly from the statistics here, there was a significant increase in the number of children who received rotavirus between the last quarter of 2022 and the first quarter of 2023. And of course, we know that diarrheal disease is still one of the most important causes of mortality and morbidity in children under the age of 5 years. So what exactly happened here? How did Ekiti State and how did you bolster the resources in Ekiti State to make sure that people increase the uptake of rotavirus?
All right, thanks again, Dr. Renner. And let me first start by appreciating the team that is putting this together, led by Dr. Feji and her team, under the Nigerian Solidarity Support Fund. I think this sort of avenue that provides an opportunity for commissioners to speak to what they are doing, sometimes some good stuff, sometimes not so good stuff is critical, because it's a mutual accountability framework. On one hand, we're able to share our thoughts as to how we're improving things, but also hear and get feedback from people as to where they think we could do better. So I think this is excellent, and I would be certain to encourage my colleagues to to ensure that they are also on this panel going forward. To respond directly to your question around what happened between Q4 2022 and Q1 2023, I think a number of things, but a large one largely being the introduction of rotavirus in the States. And that was the first time we got rota introduced into our state was in 2022, Q4 2022, right? And that pretty much explained what you consider the low coverage of rota in 2022. But we have a very robust team, very focused on getting things done, very well motivated. And so after the campaigns were done in Q4 2022, we went back as part of our performance management framework to rethink how best to ensure that we can reach kids across and be certain that we provide that coverage is effective across the entire state. So there was a meticulous plan around how we enlisted children who were eligible for vaccines, particularly rota vaccines, very concerted efforts both at the state and ward level and local government level as well, ensuring that we reached all the different outreaches, settlements to vaccinate the relevant population. And following up aggressively with shit from MPHDA, but we sent those vaccines to the local governments and then to service delivery points. So it was, again, just in sum, it was first that Q4 2022 was our first introduction of rotavirus vaccine in the States. Recognizing how we performed from that, we learned what needed to be done better to increase coverage in the States. And that's why you see a remarkable difference between Q4 2022 and Q1 2023. Over.
Very many thanks, Honorable Commissioner. I mean, so it's really amazing that the rotavirus vaccine was introduced and uptake was almost immediate because, I mean, again, one can speak to vaccine hesitancy, which is rife in a lot of states in Nigeria due to suspicions, of, beliefs. Clearly, that didn't seem to be a problem here. Is vaccine hesitancy a challenge in any way in Ekiti State?
It is. There is certainly vaccine hesitancy made worse largely by the dark side of what I call social media. People buy into and create all sort of false text messages that is sent, particularly around WhatsApp and Facebook. But we have, again, like I talked about the team and working with some of our partners, we've introduced a media monitoring team that sort of like scours the entire net for things that have to do with Ekiti, both on net but off net, right? To get a sense of what's the information, right, that is going out there. And we're aggressive about correcting that as quickly as possible. My team is almost always on radio at least once a week, speaking to specific things that are bordering around public health goods, whether it's immunization, whether it's public health emergencies, or even just around our health insurance program. We also try to leverage as much as possible using what we call institutional structures, religious leaders as an example, traditional leaders as an example, to encourage our people to ensure that they take and use the vaccines. But I think just in addition to that, we don't push vaccine from a place of the why not. We push it from a place of, from a place of this is bad, so you should take. If you don't take it, something bad will happen. We push it from a perspective of this is the value add, right, to having a vaccine for your child. And I think that resonates fairly well in the state. It doesn't mean that there's still not some hesitancy, but as much as possible, we try to correct it. And like I mentioned, we hold the service delivery providers, i.e. the facility officers, very responsible for the data that we get. And we encourage them where they have issues to address this point and concerns.
Well, I mean, that's absolutely brilliant. So, I mean, the idea that benefit should be emphasized rather than consequence of not getting the vaccine. And I think that's one way of getting to them. One of the statistics that I came across in the charts that was, yes, I think it was, let me see. Okay, yes, it was this one with the mosquito net. So proportion of sample children 0 to 59 months that slept under long-lasting insecticide nets the previous night. I know the previous night is a rather short duration to try to determine what the behavior over the last 2 years has been. But we know that malaria, of course, is a really challenging problem for us here in this part of the world. So I guess my question is, it didn't change between Q4 to Q1. So I guess my question is, are the nets available in Ekiti State? And if they're available, are they simply not just using it because it's particularly hot in Ekiti State at night?
No, you've touched on both points. The first is availability, and there are certain commodities and consumables that are states where we're grateful for what the federal does in terms of support, right? Commodities around HIV/AIDS, commodities around tuberculosis, and commodities around malaria are largely supported by federal partners and development partners. In the instance of malaria, it is the Global Fund, it is the Presidential Malaria Initiative of the US, and more recently, the World Bank. So for a long while, the Global Fund and the PMI had about 2/3 of the country covered with respect to supporting for malaria. And that included the long-lasting insecticide-treated nets, the seasonal chemoprophylaxis, and all the other consumables and commodities that will be required to address malaria concerns. We and 13 or 12 other states only recently got support from the World Bank to address some of these malaria issues. So that's created the gap in terms of availability of commodities, in this instance, the long-lasting insecticide-treated nets in 2022 and 2023. And that's why you see it. As a matter of fact, if you stretch this probably to Q4 2023, you won't have seen that much variation in the percentage of people who use the nets, right? But then there's availability of nets, and then there's use of nets as well. So that speaks to availability of nets. And on use, I think this is the realities around, the weather situation in a country where there are still challenges with power nationally, right? And, how people feel comfortable enough to use the nets. Anecdotal experience from my state suggests that where the nets are available, people do use them, except when the weather is too hot and maybe there's no light at the time. So I think the way we're approaching it, having discussed with the Federal Ministry of Health to ensure that we can get this nets in, is let's even be sure that we have the nets. And then the second order conversation comes in with respect to the use of the nets. But now, alongside 12 other states, we're engaging to ensure that we have nets coming. And from there, we will certainly distribute to the communities. We'll sensitize them on the importance of using it. Prevention, like we all know, is better than cure. And, sort of monitor how well it is being used, and even train them on how to tie the nets on their beds.
Thank you very much, Honorable Commissioner. I mean, it really has been unbearably hot in the last 1 month, actually. So who knows? Global warming might actually be a contributory factor. But I would like to just ask you, and once again, congratulations on being recognized as one of the best performing states in Nigeria on disease surveying itself to leverage the use of innovative technologies to improve immunization outcomes. So things like drones delivering vaccines to hard-to-reach areas. So I'm using that. But in general, how is Ekiti State positioning itself to use tech to actually leverage and to improve immunization coverage?
So we are certainly not using drones, and the reason is simple. Ekiti State landmass-wise is 80 kilometers by 80 kilometers. There's really nowhere that is as hard to reach as states like, say, Niger, where Some places will take almost 24 hours. Between Mina and Kanji, as an example, probably takes about 24 hours to get to. There's nowhere within Ekiti, if the road is good, that you can get to from Ado, which is the capital, within 1.5 hours, right? So we don't leverage on drones to make vaccines available, but we do other things that we consider important. The first is, about 5-6 weeks ago, I had a discussion with my team alongside some of our partners, and some of the things that were said with respect to 0-dose immunized children in Ekiti. And I told them very clearly that was completely unacceptable, that would have children in Ekiti that are unimmunized. So let's get going. Last week and this week, there's been a lot of outreach that is going on to ensure that we rapidly reduce those numbers, but also is to begin to even enumerate, the children that we have. So we are certain about the denominator that we are working with. And within that enumeration that will then take place, you have to geotag the communities or the households within which those children are, and collect the guardian's phone number or parent's phone number. What that allows us to do is, once you overlay that on their cards, then you get a sense of when next the patient is likely to need to access the next vaccine. So we can send simple SMS. And that's such a simple but very effective way to stimulate demand using technology. But also there is, when you then get into things like outreaches, right, where we can leverage on GIS maps and open data kits to be able to, as electronic tools to be able to collect, not just collect high quality data, but also to actually be certain that we're reaching the kids that should be reached. And I give an example. Last year, as we were looking into COVID, we got some support from one of our partners who wanted to help us ramp up our COVID immunization numbers. But we were very clear that, yes, it's important that we get COVID going, but it's the same health workers who are going into the field and will likely be meeting children. So it's important that we include RI vaccines in this regard. And so again, using GIS mapping, we knew, concentration areas of high population density, and we deployed more teams to such areas where we also could then stimulate high vaccine demand. And within a 4 weeks period, we had vaccinated by 180,000 people in the States, a little under 8% of the entire state population. So I think that being able to, and that we did that because first we used the GIS mapping to figure out areas of high concentration in terms of population density. Secondly, we used the ODK tool, right, to collect the data. And we had a control room who was looking at what was going on. So we could see how people were recording because we had recorders. We could see how people were vaccinating. And if there were any issues, we could course correct down the line. These points I've made speak to sort of like the supply related things that you could do. So the facility level things, the community level things that you could do to improve that. But also on the demand side is our own state health insurance program and our flagship health insurance program, Ulerawa, which essentially, right, using technology, reimburses primary healthcare facilities for every single patient or child that is vaccinated in the state, right? And it's been such an effective tool. I do recall that in the last 1 year, just a little under about 100K, and please don't quote me on this, I need to be sure, I don't have the data right in front of me, but quite a significant number of children have also been vaccinated in the States because the facilities do know that once they vaccinate, then they get reimbursed for the service that has been delivered.
That's absolutely brilliant because incentivizing the vaccination process is definitely one way of making sure that uptake is significantly improved. As the chairperson of the Nigeria Commissioners for Health Forum, what are some insights into why some Nigerian states are faring poorly regarding vaccine coverage?
There are three issues. Broadly speaking, there are demand side related issues, right? As there's knowledge of people in terms of what they know, right? If you then know, there's your attitude, right? And that speaks to, okay, yes, I know that I should get the vaccine, but am I taking a position of I cannot be bothered about my child taking it, right? So there's attitude. The third being an opportunity cost that comes in. Nigeria is a largely informal sector, a lot of people working in the informal space. And so the woman who lives or works in that rural area selling her tomatoes is going to ask herself, what is the opportunity cost of me not selling my tomato today to take my child to a primary healthcare center to get vaccinated? It means I probably would not be able to make my money for today, right? My income for that day, right? So there is that conversation to be had, and that's why I tell people that I frown on when patients go to PHCs and they tell them today is not a immunization day. That's a missed opportunity. So those demand side issues have implication on ability to rapidly improve vaccine coverage. I think there are also supply side issues that affect this. And one of them is the geographical spread. So yes, we do have facilities, and in Nigeria currently we have about 17,000 plus, about 30,000 plus primary healthcare centers, public, private. About 17,000 plus of them are public institutions, mostly health posts and health clinics who ideally should be doing vaccine outreaches. But when you look at vaccines or more broadly immunization, the way it works is you have what happens in the facility, which they call fixed post. Then the facility is meant to have like outreaches within a 2 to 5 kilometer radius of within which that facility is located. And then sort of like more mobile engagement that allows you to go to more hard to reach areas. So the geographical spread to be able to adequately cover really distant, hard to reach settlements is something that needs to be thought about. And I think that's why some of the current ministers push for more than 1 PH per ward to 2 PHs per ward could help solve that. The second, of course, is commodity availability, right? And that commodity availability is at different levels, right? There is commodities or vaccines the vials getting from MPHCDA warehouses to state, and then also from state to LGAs, where then they're carried in cold boxes for the outreaches. The third is around, human resource availability, right? In across board, right? It's the same human resource who is expected to do the recording and who is expected to see a patient in the facility that is expected to do the outreach. So there's a conversation even at the Nigerian Health Commissioners Forum around how do we address this going forward. And then there's a data management issue, right? So we may actually be vaccinating, and I've seen that even in instances in Ekiti where sometimes they've vaccinated, they've recorded it in the fixed post register, but they've just not translated it to the DHIS2 or any of the other documentation. So that's on supply side. The third one is around the governance, right? There's a lot of fragmentation of service delivery in the system. Again, I sort of alluded to that earlier on. You have immunization teams going out. Then the week after, the state health educators decide that it's important to go out. Then the week after, you have the public health emergency team, DSNOs, and the local government, say RRTs, rapid response teams, deciding to go out. Or every other week, one team is calling the facility people for training, right, in the capital. So this fragmentation of service delivery can inhibit or impede the ability to deliver service. And I think from our perspective as commissioners from the forum, this is something that we're very keen to address and just defragment the system and align services that can move in the same direction. In the past, we've had challenges with oversight at the different levels, at LGA, at state as well. So this is something that needs to improve. And more broadly is the PHC accountability, right? With PHC accountability, we speak to even things like budget availability and making sure that the resources are available at the right time. And I give an example. A number of states are currently undergoing the NIPD campaign. So that's one of the polio-related campaigns, Immunization Plus campaigns. If you don't plan on time for those campaigns, even though you would get support from the federal to do it, but there's a state funding component that is required. So if that is not properly planned for you to get approvals converted into cash, it can derail or delay your program, right? So that accountability between SPHDA and the commissioner, between the LGA teams and the SPHDA is critical to address some of these challenges. So in some, like I mentioned, there are demand side issues, knowledge, attitude, financing conversations, there are supply side issues, geographical spread, commodity availability, human resource for health, and data management. And then there are governance issues around PHE accountability, fragmentation of service delivery, and limited oversight.
So essentially, you have really given us very important insights on what the challenges are, and they are immense, but clearly, you are doing something right in Ekiti, as evidenced by the, award. Data is really important in the sense that we might be vaccinating children, but not really capturing them. And there's actually a slide somewhere here that actually talks about the disparity between children who are immunized by card. Let me see if I can find that slide, versus those who, yes, so comparison between proportion of children immunized by age, card, and by history. So in Q4 2022, we could see that those immunized by card, almost 70%, and those who could actually say that they were immunized by history were actually significantly lower. So we can see that, so sometimes challenges do exist in, knowledge and sometimes even data collection. But the slide I really wanted to talk about here was the proportion of sampled women whose delivery of their 0 to 50, of their babies, of their children, 0 to 59 months, were attended by skilled birth attendants. The darker orange, this is last quarter of 2022 and then the first quarter of 2023. And the numbers didn't change very much. So we found out that 74% of women were attended to by skilled birth attendants. Yes, 74%. So the figures essentially didn't change between those two quarters. So 26% in Q4 2022 were attended by non-skilled birth attendants, and 24% in Q1 2023 by non-skilled birth attendants. So the figures didn't change very much. So why do you think this might have happened?
It's a good question you ask, and it's something that we as a state as well are working on to ensure that every woman who delivers in Ekiti State is attended to by skilled birth attendants. It's not because not enough, but it's not so much as to us wanting to, it's nice to have 100%, but it's way beyond that. There's the quality of care, there's the life involved, life of the mother and life of the child, right? So it's important that we do it. But we also do recognize the sort of like existing limitations within the system, and we're working to sensitize people in this. I've heard all sorts of anecdotal reasons why people prefer to deliver in certain places, prayer houses, and what's not. But I think, again, when we unpack what we call a skilled birth attendant, what we typically see is more often than not, they use a very vague and broad term of traditional birth attendants. And that's completely different, because you could have a faith-based home that has a retired midwife, as an example, and may be able to provide some care. And then you just have the accurate, those who don't have the skill sets to be able to deliver it. But I think more broadly as a state, it's very strong sensitization. Again, like I mentioned, we work closely with institutional structures, so the religious houses, the traditional rulers, and now more recently, because we only just had new sets of local government chairmen, we want to work more closely with them to ensure that we hold them accountable for what we see in their own LGA. As a matter of fact, just 2 weeks ago, I sat down with my team to look at the expected number of deliveries that we should have by ward, based on MBS MPOPSI population data, right? That we have in the state. And so I've been sitting down in the last 3 weeks very regularly with the LGA medical officers of health to say, I will hold you accountable for the number of children who are delivered by skilled birth, but also for RI conversations. They appreciate that because it gives them an opportunity to be able to engage and share their concerns, but it also gives me a way to hold them accountable for results. But I would also support them in getting that work going. So it's more community dialogue and sensitization, is engaging people, is letting them understand the risks involved in going to places where they may not have the capacity to be able to address complicated issues, if there are, and you can't tell if you've not even gone through maybe an ANC process that is able to adequately pick up certain things, or maybe there's been some challenges in that area. So in some, we'll continue to engage. It's not a day's journey, but we'll continue to engage with the communities to encourage more people and sensitize them. We're also very aware that there is a flip side to it, which is health worker attitude, right? And I was discussing this with someone 2 days ago, and one of the things that came out clearly was customer service is not, it appears almost as though it's foreign. Real good customer service is not, we don't take it as a core component of, service delivery, not just in health, just across board. So this is something that for us, we're very interested in improving health worker attitude. We've put in place some quality of care measurements around this, and we'll continue to push in that. So I do hope that if you've done the rounds of commissioners over the next, say, 12 to 15 months, and maybe I come back, I'm almost certain that you won't be seeing the 24% non-skilled births that you've seen, and that would have reduced that number significantly.
Anything you've spoken to the fact that there's something to be said about customer service and making the client, prime. Ashino has a question here for you, and it goes like this. It says, for Commissioner Filani, have you considered engaging private sector providers that can take care of the data collection bit of things, while the PHC personnel focus on carrying out the actual outreach itself? This will facilitate effective delivery of these vaccines.
Yes, and we've done that, but on an ad hoc basis. Where we have targeted campaigns, we use we have ad hoc staff that we use, and we train them. Some would collect. Some serve as like community informants, some serve as, as like health educators, and some serve to support the reporting or recording of the data that is being collected. But that's not a sustainable approach to build a health system on if you want to routinize and strengthen a system. So yes, you can do it from a targeted campaigns perspective, but on a more sustainable plan to build a resilient health system, you have to either ensure that you have the right number and skill or cadre of health workers, motivate them, train them appropriately, and hold them accountable for, putting down the results and just delivering the service as it were.
Fantastic. Many thanks, Honorable Commissioner. Thank you very much, Adewale Fashino, for that question, because collaboration between the private sector and the public sector is key to ensuring that healthcare delivery is maximized in Africa. Honorable Commissioner, all too soon, we've come to the end of this discussion. As much as there were so many other considerations that I would have loved your insights on, time is fast spent, and we appreciate the insights that you've given us, because, it's clear that there's so much that we can do as far as leveraging technology is concerned in ensuring that vaccine coverage and general healthcare delivery is maximized. So once again, thank you very much, Honorable Commissioner, for attending this session. We really appreciate your time and presence.
Thank you, Dr. Rana. It's a pleasure having me, and it's been an extreme pleasure speaking to everyone, over just a little under 100 plus people who are listening in directly, and I assume more via the streamlined services. And a big thanks to Dr. Feji and her team for thinking about this and putting it together. As a forum of commissioners, we look forward to working with you on this, and I can put it out there that I will get as many more of my colleagues to also participate in this and the subsequent ones. Thank you, and over.
Very many thanks. So let me stop sharing my screen. Okay. So everyone, thank you all once again, and thank you for the questions. The next aspect of this session is going to be the question and answers for the panel. And of course, just to quickly reintroduce the members of our panel, we've got Cyril Sek, we've got the representative of Professor Moji Adeyeye, who is the DG of NAFDAC. Sorry, give me a second. Beno Yakubu, and we've also got Anna Fernandez, Dr. Choman Wakama Akano, and Dr. Lawal Bakari. I would like to actually start with Beno Yakubu, and of course, once again, participants various speakers. So I think we all know how important NAFDAC is as far as delivery of not only vaccines, but healthcare in general in Nigeria is concerned. And so I would like to ask,
Hello, you're breaking? Hello? Hello? Can someone hear me?
Yes, we can hear you. I think Dr. Rena is probably experiencing some network issues, but he's currently not audible.
Thank you. Let's give him a few seconds to reconnect.
Unfortunately, I can't hear him as well.
Please just give us a few seconds. We're trying to connect with him. I'm sure he'll be back soon. And if not, I will step in. Thank you.
I'm back actually. My apologies. I've had to switch my network, but unfortunately there was a total blackout on networks yesterday, and I'm not sure it's entirely restabilized. And I hope I'm very clear.
Yes, you are.
Fantastic. Thank you so much. So, Mr. Yakubu, I'm really sorry. I was asking, how has NAFDAC been able to leverage tech to track health commodities and vaccine logistics across the country to prevent wastage and ensure availability? Because, of course, as we all know, comes to vaccine delivery, things like the cold chain matter. So how has NAFDAC been able to leverage tech to make sure that commodities are available and vaccines are delivered?
Thank you so much. And I just wish my DG would have been here to maybe should have say more. But then let me just answer your question to the best of my knowledge. Again, NAFDAC has been on its forefront to make sure that all health commodities, especially drugs and vaccines, really get to the rightful people who needed it. Again, based on that, I think at home, even before the tech, NAFDAC do make sure that make sure that all the storage facilities that store thermolabile products, including vaccine and drugs, are adequately put in place. We do get to those sites to make sure we do what we call cold chain facility inspection to make sure they meet our standard and guidelines. Again, apart from that, I think with the coming of this new DG, she put up some technological into place. As it is now, I think when COVID struck, she had to join hands with develop regulatory authorities to to develop this app they call Med Safety app for use by both service providers as well as even ordinary person at home. It's a simple device that can be downloaded and used to collect adverse events following immunization for vaccines and all drug-related ADRs. So again, when you collect, you put all this information you have, NAFDAC will receive them and will treat them accordingly. Because in-house, NAFDAC have committee that review all this data, as well as having some experts outside NAFDAC to make sure that this data are properly reviewed and again uploaded where it's supposed to be. We are part of the pharmacovigilance system, global pharmacovigilance system. So we send our PV data to Uppsala. So to make sure that every adverse events we collect or adverse drug reaction we collect here goes back there. So it's publicly available to the international community. And again, for other health commodities, including vaccine and drugs as well, NAFDA has key into the global standard one system whereby every batch of a product that comes as it is now, and every lot and batch of a vaccine is being traced from the moment it comes into the country, or if it's manufactured here. For drugs, there are some specific drugs that we've started with as it is now. Not all drugs are involved in this now, but what we've done, those drugs that are really of very important, we make sure that we key them into the system, the global standard one, so that we can, right from even from the manufacturing facility, we make sure you put that coding in, so that NAFDA has a database. We trace every batch and lot of a vaccine that gets into the market till the final user. So with that, every vaccine that comes into this country, NAFDA can trace it wherever it is. We'll know where it is and we'll know how it's been delivered. So if there's a break in cold chain or if there's any issue, NAFDA pick this information and gets there and retrieve that. If it means recalling, we recall it without any much problem. And I think that is where this DJ has taken NAFDA to at the moment. Over.
Very many things. So for all panelists, I would like you all to turn on your videos so that when you're speaking, you can be spotlighted subsequently. Thank you very much. We know that it is a daunting task to actually be able to track all those drugs and all those vaccines, because these are drugs that amount to millions and doses that are thousands. Billions, and so that requires, some kind of technological intervention, and I'm glad that that is being harnessed by the current Director General. I would like to
I'm losing you again. I think we've lost you again.
Yes, we are.
Apologies for that.
I believe he was trying to ask what challenges you have experienced in implementing the digital solutions you mentioned in hard-to-reach areas that have limited internet connectivity, and what are the lessons that have been learned?
Yes, I think that challenges, I think like everybody will know very well, we have challenges of poor power supply, and again, internet as where we is experiencing now. So I think with that we have limited solutions to provide for this. But I think what we try to do is to make sure we sensitize everybody so that when an opportunity comes, you have all these facilities, you report. And especially we do that sensitization to the health caregivers. NAFDAC is out every day to health facilities to train them on how to harness this very, very opportunity to report safety issues to the agency and even to the communities. We do community engagement now and then to make sure the community are aware that there's need for them to be vigilant as well in terms of using drugs, and not just using drugs like that. So I think that particular problem is universal as it is now. Over.
Thank you very much, Mr. Yakubu. See, unfortunately, I'm not even living in a village. I'm in the city, and my internet connection is this unfortunate. So, what about those people that are living in the hinterland? I mean, the challenges are immense, but hopefully we will get there at some point. I had wanted to ask Dr. Lawal Bakari before my network acted up about how a PID alert applied design thinking to advance its capabilities in addressing the new health challenges in Africa. So, Lawal Bakari, did you get the question?
Thank you, Dr. Rena. I think I got your question. It's about how we use design thinking in dealing with some of the problems that we have solved. I think first thing is most of the scenarios that we've had to work in are usually crisis related. So if you understand the type of observation that goes in those kind of scenario, it is usually chaotic. So it creates a very exciting experience is in the process of just observation and learning curve in the whole design process. So we don't have the opportunity of asking too many questions. So we have to apply the chaotic environment itself as our learning environment. So for instance, during Ebola, the learning environment was the online behavior, using social media feed as the source of understanding the level of fear and anxiety in the public and the nature of questions and needs that were emerging. And then that allowed us to also derive the sources of capacity that we had to deploy. Because of, again, the nature of the problem, it was beyond what just the classic healthcare human capacity ecosystem could deal with. So we had to even work with hardware engineers, software engineers. Sorry, whenever I disappear from the screen, it's because there's no power where I am. So I think it's still speaking to the type of realities that they are dealing with. But where I'm going to is that we have had to work in those learning phases that way. Now, at the point of identifying the problems to solve and the methodologies to apply, we've used prioritization techniques that are usually based off interacting in the response ecosystem. So sometimes we've embedded in response teams at sub-national level and at national level to kind of understand where the arrowhead of the responses to most of those crises are being. And otherwise, we use consumer needs, sometimes based off how people are relating with the arrowhead of the response itself. So scenarios like monkeypox, right? Scenarios like meningitis outbreaks, we've sometimes had to use, like, look, what is the arrowhead of this crisis as probably the outbreak is spreading, using technologies to target those who are at most, who need the types of interventions we've had to provide, and then use now kind of simple technologies to respond. So we are very big on using easy to adopt technologies, as opposed to just thinking in state-of-the-art assumptions. Sometimes we follow the user access as the driver of technology options. Sometimes we've had to use offline systems guided by technologies like GPS, as simple as that would be, using internet to guide SMS, just so that we are not thinking above the capacity of the consumers to adapt the technologies that we've deployed. Earlier when I was talking about the way we form teams, we've had to use a principle in design that lets you identify the best capacities to solve the types of problems that you have. So if the problem is financial, don't go at it as if a doctor can equally solve a financial situation, because again, there are instances where the problem is how do you get resources in the hand of those who have to move from time to time. And then as we've done this over the years, it also has given us kind of a bank of insights that now came forth when we had an outbreak like COVID-19. So for COVID, we've already learned behaviors at places like point of entry. By the time we had COVID, we've already learned things about decentralized messaging. So when an honorable commissioner was talking about how misinformation is sometimes guided by social media, our understanding of that was based off our own study in Lagos as of 2017-18, where we were looking at how social media over centralized messaging. So if I report that there's an outbreak in my hometown in Ise-Ekiti, the people in Iowa, US will get it at the same time I throw that information on social media. And that kind of even gives a consumer who has no context in terms of the behavior of the genome of the microbe that is probably causing the outbreak to misinterpret it. So what we did was to create a decentralized social media kind of technology, something that behaves like Nextdoor. So those who understand Nextdoor, is something that says when we release this information, it only goes within the community that the owner of or the person that has access to technology has chosen to have access to information. So if I say, look, I want to know what is going on in my hometown in Ekiti, and then I want to know what's going on around where I live, I would be able to just receive information from those places. And then we can now use a higher level information access to define what is a national relevant message. So if there's a nationally relevant message, it now gets across to everyone. But that minimizes unnecessary exposure. So we had learned that before COVID came, and we'd already built some kind of technology stacks around how we decentralize messaging. So when COVID came, part of what we had been reflecting on, so I was even in Germany then, part of what I was exploring in Germany was the sustainability strategies to some of these concepts. That when we have now developed technology, the cost of building and running technology is usually high for sometimes the consumers to be able to pay to use them. And while taxpayers' fund might be the next option, your solution might not be the immediate priority for the public sector. So because of that, we were reflecting on the sustainability models, and we're looking at sectors that some of these concepts might be of great value. So for instance, in the middle of COVID, we had been looking at travel sector. So when we now had a scenario with travel and travelers' behavior, we were able to deploy some of those decentralized messaging for international terminals around the world. And so when people are coming from different parts of the world, they might be able to find what is relevant to them in terms of where they will arrive in Nigeria. And that kind of created what we used for the COVID pass technology. So, so the work we are even doing now is still continuing in that direct-to-consumer assumption. So we continue to learn by and by and see where the real head of sustainability stands. So not just building technologies because they are beautiful, but because we know that most of what we do for crisis scenarios, behaviors in crisis scenarios are totally different, even for funders, for beneficiaries and communities. And being able to now adapt those tools to the point where we can now begin to embed them in the public sector. So some of those practices that we've learned, we've been able to embed them in institutions, and some of them are running without even with governments adopting them and using those methodologies. So that is where we are right now with those kind of assumptions. Thank you.
Okay, I mean, so that's absolutely brilliant insights, because I mean, the decentralization of information, I think, is key in making sure that people have access to, updated information that is readily accessible to them. I think we should all be advocates of design thinking. Thank you very much, Bakari. Well, I would like to ask Anna Fernandez Del Rio. Anna, I would like to ask you, what are adaptive interventions and how can they help us improve vaccine uptake in Africa?
Yes, so hello everybody again, and it's been a pleasure to listen to all the speakers so far. Very interesting insights. I would like to elaborate a bit on adaptive interventions, as you mentioned. So at Causal Foundry, we build data-centric digital solutions, but maybe more importantly, we also integrate with already existing solutions. We think and we use adaptive interventions through these digital applications. So how this works is there's a myriad of digital tools that from in many relevant aspects that pertain these vaccination uptake, from supply chain to actual.
Sorry, Anna, sorry, I'm really sorry to interrupt you, but would you please on your video?
My video is on.
Oh, it's on? Okay. Sorry,
Yes.
I'm from my end. All right, sorry, please go on.
Okay. I can you see? Okay, yeah, I think so basically these digital tools that they need to be useful for the end user, these digital tools that can be used in supply chain, as I mentioned, but also in healthcare facilities for patient management, for communication between peers, for capacity building. There's also tools for patients themselves or for parents in this case, connecting them with their healthcare providers, or this communication can be done through different means. But these tools that are already offering some service to their users, the actual use of these digital tools generates very, very rich information on what's going on, both clinically and behaviorally. So if we connect to these devices, to these tools, and we track and label these data adequately, this is what we do at Causal Foundry, and we have it AI ready, then it's very easy to use this information to enrich these applications with these adaptive interventions. By adaptive interventions, adaptive is adaptive because they are going to continually learn from the data that's incoming. So from previous decisions, actions that have been taken and their results, the interventions are going to adapt to what they are learning online from what's going on, and they're going to learn how to adapt to each individual user, be that a supply chain actor, or be that a healthcare worker, a community healthcare worker, or be that an actual patient or the parent of a kid that needs immunization. It's going to be able to adapt that intervention to that individual user and their evolving needs and context. Okay, and if we are integrated with these digital tools, the additional it is the source of the data, of the information that's going to inform those interventions, and it's also at the channel that can allow us to deliver that intervention directly to the end user. So by intervention, we mean any sort of suggestion, recommendation that can be made through messaging, through notifications, or actually adapting the actual content of the tool or the workflows within the tool to each individual user. How can this help to drive vaccination uptake? Well, I think there's the first very, very important thing is it enables the collection of data. And as we were discussing and previous speakers were discussing, having quality data, it's a prerequisite to be able to make evidence-based decisions and to see if different interventions, be these public policy interventions or other specific interventions, are working or not. We need to have high quality data. And the beauty of these tools is that they should be providing, it shouldn't be an additional burden, the data collection. The data collection happens organically through the use of these digital tools. Okay, so this is the first very, very important thing. It allows us to have the data, to collect the data that is needed to evaluate what is happening or not. And then adaptive interventions can be used to give these personalized recommendations or personalized support. and also in resource allocation. Okay, so for example, they can be used for supply chain management optimization. Okay, we can use the incoming data to have predictions of demand and to try and give recommendations to different, for example, facilities to remain well stocked, and even for public health reasons, if there's a shortage of vaccines allocations, to give recommendations on how to allocate them to maximize the positive impact or minimize the number of children left under immunized, and especially the ones in the more vulnerable populations. They can help to personalize content so that we can have better outreach campaigns, better campaigns to reach awareness, so they can actually provide also additional support for healthcare workers or for community healthcare workers to suggest which, for example, households might be in more need of someone coming to talk to them and explain them about the benefits of immunization. Okay, so both for educational interventions, for supply management optimization interventions, for resource allocation or prioritization, be that in terms of vaccines themselves, but also time of healthcare workers, of community healthcare workers. For all of these, adaptive interventions have proven to be very effective. Okay, so they provide us with the data to assess if they are being effective or not, the interventions that we are running. They provide a source of personalization. This can include, for example, deciding which incentive could work best for each type of healthcare worker or of individual, for example, parent to bring their child for immunization. And they work very well for resource allocation, be that a prioritization of how to allocate resources or time of healthcare workers themselves. I could elaborate more and more, but I would I think we can have additional questions.
Hi, Dr. Rena, are you there?
Yes, I'm here. I just
Okay,
reconnected. So I had heard Anna talk about how there is more effective distribution of vaccines as a result of adaptive interventions, so that the area of needs actually gets those vaccines that are required, and of course tailor-made campaign messaging, so that to know that you're sending the right message to the right set of people. It's almost like the algorithm is recommending the videos that you like to watch on YouTube. So, but in the healthcare sector. So everybody needs adaptive interventions, and these insights are really valuable and are very important. So thank you very much, Anna.
It is exactly what you mentioned, is this personalization that it's used in many other areas to drive profit, but to use them not to drive profit, but to drive equitable access to healthcare for everybody.
Absolutely brilliant. Thank you so much, Anna, for those insights. Dr. Choma Wakama Akano. So this question goes to you. Now, digital platforms such as social media have been seen as both a tool and a weapon. So, with the onset of disinformation, misinformation, and fake news, what are your thoughts on how we can better utilize the positive side of technology and digital platforms for health advancement, especially in improving immunization coverage? Because, of course, I know that you are very passionate about cervical cancer, and that you have annual, cervical cancer campaigns in January. And I've been part of those campaigns before. So, with the recent introduction of the cervical cancer vaccine, you are at the forefront of making sure that people know about this vaccine. So, how have you used social media, and how can we use social media to actually help this uptake in the face of misinformation, disinformation, and the weaponization of social media to make sure that people just don't get the right information?
Okay, thank you very much, Dr. Rena. Thank you very much to the organizers of this beautiful event. It's been a pleasure, honestly, sitting back and listening to all the amazing speakers and panelists. I think my job has been made easier, having had Dr. Lawal and Anna go ahead of me. I think I'll just piggyback off what Anna talked about when she was talking about adaptive science. And she mentioned something about the importance of data. Now, one of the beautiful things about data or having data is that it helps you have tailor-made strategies. And that also applies to health comms. You mentioned HPV vaccination, and of course, every other vaccination that we have had, and we're still having in Nigeria. It's not been made easy with the recent misinformation, disinformation campaigns that we've been seeing, fueled by a lot of factors, including what I call it distrust in not just the government parastatals, just people have general distrust, for the system. And of course, social media, while being a vital tool, is also a tool for, as Dr. Lawal said, it decentralizes messaging. And the speed of messaging on social media is both a blessing and can be a curse. And that has been seen both in not just the vaccines, but every other aspect of public health. So as to the question, what can be done? I think the very first thing I'd say is everyone is involved. It's a multifaceted thing. It's not just enough to say, oh, go out there and put counter messaging or go out there and tell people, oh, this is a lie, this is not true. But I think we all need to look at the various stakeholders involved and understand that one person missing in action is going to really impact negatively on any outcome that we're going to have as regards health messaging. And by stakeholders, I'm talking about you and I'm talking about the government, I'm talking about the healthcare workers. So everyone who is in the healthcare system, from the policymakers, doctors and nurses, everybody is involved. And so the reason I say that is because I give an instance. Most of the work I do, of course, on the social media front is myth busting, sharing correct information, having online campaigns. But then I remember having a conversation with someone when I went for Christmas, right, this December, and it was about HPV vaccination. And then she said, oh, that, she saw the messages and yeah, even though she had her doubts, but then the reason she really didn't make her daughter take the vaccine was because she went to her doctor and she asked her doctor about it, and her doctor didn't say it was bad, but her doctor didn't say it was good. So he just said, if you want to take it, Sha, it's okay, right? So you see, we are doing a lot of work on the social media front, but then offline, we still have a lot of people who are yet to be on board on this movement. And so that brings me to the most important thing, which is empowerment, educational empowerment of every stakeholder. Everybody firstly needs to be empowered enough to know that this is important. This is how you talk about this particular information. This is how you disseminate information. And there are some do's and don'ts, when you are trying to bust myth, trying to, counteract certain disinformation out there, because there's a thin line between you removing that barrier or trying to, trying to bust the myth and propagate that same myth. It's just a very thin line. So that's why one of the things that I'm very, very keen on is, firstly, we need to empower every stakeholder. Then the next thing is, of course, this involves strategic content dissemination. Now, collaboration with key influencers, and then, employing targeted campaigns to educate and address concerns. I'll use the COVID-19, for example. It was one of the most beautiful campaigns that I was involved in. And I was really impressed to see that every sector was involved, the government, the NGOs, the international NGOs, everybody was involved. And one of the things that I would say that worked, of course, it had its challenges, still does, but one of the things that worked with information dissemination as regards COVID-19, is the fact that everybody was involved. The key influencers were carried along. I'm not just talking about your key social media influencers. I'm also talking about community influencers. I remember doing I was one of the influencers that did a key messaging campaign in my local language, in Igbo. So I did it in Igbo, and it was propagated to Eastern states. And that went a long way. I remember making videos in Igbo language, and that really helped. So if we must combat, vaccine hesitancy and increase vaccine uptake, we have to be very strategic in our messaging. And you can't be strategic in your messaging if there is no research, there is no data. And that's why I said I'm going to piggyback off what Anna said. So we need to find out what's the pulse of the people. What do they like? Our messaging should be very tailored. The way I'm going to talk to somebody who lives in Lagos State is quite different from the way I'm going to talk to somebody who lives maybe in the north, someone who lives in the east. How do we get people in hard to reach areas? So our messaging should be very tailored. What's your language and how sensitive it is very important. The way I'm going to talk to the millennials is definitely going to be different from the way I'll talk to the baby boomers, like my parents, and then of course the Generation Z. So we need to have everyone on board, and that's why I said strategic content dissemination is key for us to have, for us to achieve whatever we want to do as regards vaccination, HPV vaccines inclusive. It's not enough to say, let's do it the way we've been doing it, the way we want to do it, the way we feel is right. We need to do it the way the people want it. It has to be tailor-made. And so you have to first go to the people, find out what their pulse is, because I just came across, I'll end with this, I came across a recent research, I think by Behavioral Insights Lab, and this shows a new aspect. It was talking about how the research they conducted revealed that Nigerians are more responsive to COVID-19 it was centered around COVID-19. So Nigerians are more responsive to vaccination or vaccine messaging that preaches hope as against fear. I also remember the Honorable Commissioner mentioned that when he was talking about citing examples in Ekiti State, messaging of hope. People want to hear, so when you take this, of course, you're going to be alive to see your children graduate, become whoever they want to be in life. Not for you to say, if you don't take this, you are going to die. People don't want to hear that. So for you to be able to know and understand this, you need to feel the pulse of the people, and that's true research, and data is quite important. So yeah, thank you.
Well, thank you. Thank you very much, Dr. Makama. You shouldn't tell them you're going to die if you don't take the vaccine. Even though some healthcare workers actually adopt that mechanism, like they literally threaten them into getting interventions. But people do respond more to the hopeful messaging to say that, what, these are the advantages that you will get from actually getting these valuable interventions. And I think you should key into that. So really, thank you very much. Data is key even for healthcare information dissemination and content. Great stuff. So, Cyril, I've got a question for you, and it's what visible growth has been noted in Africa's healthcare system since Africa's CDC launched its digital transformational strategy? Cyril, is Cyril still here? Okay, I think there's a hand up. Okay, I think, and I know that Cyril is in is in a conference. So maybe I should just circle. Okay, Cyril. Okay, so great, Cyril. I think I saw you pop up just now. So did you get the question?
So sorry, I could not hear what you just said.
Okay, yes. So let me repeat the question. Can you hear me now?
Yes, I can.
Great. So what visible growth has been noted in Africa's healthcare system since Africa CDC launched its digital transformational strategy?
Yeah, sure. Maybe I should have started with that earlier when I got the floor. But we're a very young organization, but what we did manage to do is to assemble a group of 75 different organizations, some of them in the, being implementers, others donors, with very specific types of expertise. And what we do is that we coordinate those stakeholders so that they can better align, their work plans, and that they share their objectives, and that the distribution of roles and responsibilities is being improved. That's a major achievement. Some organizations, even the largest, such as the Bill and Melinda Gates Foundation, or the Rockefeller Foundation, or others of those very influential donors, they do have very specific countries, priority countries, and then some member states get lost, or they're on the side. So what we do is to make sure that the various stakeholders can share, can learn from each other, can align, and that together we're stronger. So that's a major achievement, because we now have a platform. And then you may remember from my presentation earlier that we have those 5 flagship initiatives. They're already being implemented. We're recruiting staff, and if some of you may want to check my LinkedIn, you'll see that there is a position that is open right now to coordinate some of this work. But we're here for the long run. The magnitude of the effort is important. And we will support anything that help scale up, anything that help those many pilot projects that we've had for decades to be showcased, and then scale up to different regions or even to different countries. And lastly, there is this one topic that because we're discussing vaccination. Predictive analytics is critical. Everyone is very, maybe most of us use ChatGPT. We know that large LLMs, they require data. And just to give you one element, 86% of the data on the internet that is being LLMs leverage is in English. I'm not an English speaker, and we have so many different languages in Africa. What I want to say is that if we do not digitize our data to fit it into the various models, that will help us, put together those agents that can second our healthcare workers, then we may end up with solutions that are suboptimal, or solutions that are not relevant to our realities. So a very important element for us at Africa CDC is market integration. That comes with basically aligning on standards. So for health, fire is really an important one, but it's also interoperability beyond the countries. Let me stop here, maybe. But that's really our scope.
Thank you very much, Cyril, for that response. Again, I realized that you did highlight some of those interventions and initiatives that were high impact and high visibility. I think that those are the terms that you used. And I think highlighting those, I think, would be really important. So thank you very much, and really well done again for the work at the Africa CDC. Just circling back to Anna. Yes, great, Anna. So I'm really good to have you back here. So how are predictions? I think the question goes, in what ways are predictions used to target specific populations for intervention to optimize impact, and how is that implemented in Africa?
Well, there's depending on the kind of solution and the type of interventions that we want to run, the predictions that might be useful are different, but there's different types of predictions that we can use depending on the use case. As I mentioned, no, that the at the core of what we do and how we believe we can improve health outcomes, and in particular vaccination immunization ratios, is basically by connecting to digital tools and using the data that's incoming from those tools that contains very rich both clinical and behavioral information, and use that data to inform interventions that can be personalized and tailored to each individual's needs. We work, for example, with supply chain tools. Imagine tools that the different supply chain actors can use, and they can get, for example, some recommended supply distribution plans for them to modify and then approve. These plans that can be considered an adaptive interventions in themselves, and can have behind them algorithms running that are learning from previous plans and what happened and the consequences of stock shortage or not that didn't happen in consequence, can use different information of what's going on and what has happened in the past, but also of predictions. Obviously, demand predictions, and not only predictions in themselves, but also some quantification of the uncertainty associated to those predictions, are going to be very useful for the algorithm to use in the planning. They are also very useful in themselves for human planners if they want to do the plan themselves. So, for example, in this case, to make sure that vaccines are available where they are needed, then we can have prediction of demand for those vaccines. But also, when we want to, as I was mentioning, when we want to decide who maybe we need to prioritize for a follow-up or for sending a community health worker to that community to check in, be that at the community level or at the individual level, we want to have predictions of these risk of being under-immunized, for example, and also of the uncertainty associated. So those types of predictions can also be very useful to allocate time from or allocate resources from the healthcare system. Also, predictions on who might be more vulnerable from the population in terms of the consequences of remaining immunized, non-immunized, to really try to target very specifically more vulnerable populations. So even once you have someone already having some, for example, the first dose of a vaccine, you can have some predictions of the risk of them not completing the full course of vaccinations, and track them and give them more specific supports. So there's different types of predictions that can be very useful also for human decision makers, but very particularly too in how we normally work is in additional information that can be used by the adaptive algorithms to make a proposal of a specific recommendation. Also, our way of working is always making recommendations or suggestions that then a human decision maker decides whether to comply with or not. Okay, not we believe in a human in the system. Okay, so we try to make the life of human decision makers easier by providing them with prompts, reminders, suggestions that can help them focus on what's more important of their work. For example, in the case of healthcare workers, on providing the best care possible to their patients. I wanted to address, I was getting questions first on the privacy issues, and I'm very happy that this was raised, because this is definitely very important to us. And we are at Causal Foundry, we are GDPR compliant and HIPAA compliant, and we comply with any additional requirements from different governments or local authorities with the partners that we work in many different countries. One of the very important things here is that as you're working through digital devices, you don't need to collect personal information or information that would allow you to identify the actual individual. So basically, users can remain anonymous, patients remain anonymous. All sensitive information is hidden and actually who it belongs to. And always users and patients are asked for consent and can withdraw their consent at any time, and all the data is then deleted from our systems. And also decentralized clinical trials and adaptive clinical trials have been mentioned in the question, and it's something I didn't mention as adaptive intervention in itself, but of course it's also something that can be of help here, as our technology also can be used to perform these adaptive clinical trials. And of course, this could also accelerate the approval of new vaccines, which might be relevant in this case. But I think actually analyzing policy interventions and behavioral interventions are better focus of what I'm explaining than the adaptive clinical trials themselves. I hope this gave a bit of some idea of what type of predictions we can use.
Yes, indeed, it did. And I see you also went and addressed the question of data safety and protection in this field, because somebody had asked it in the chat box, and I believe that you had answered it. But thank you for re-emphasizing that. Thank you very much, Anna. So once again, please, if you have any questions, please put them in the chat box, in the Q&A box, so that some of the questions can be answered live. I see that there's one question, and Mr. Yakubu has kindly answered some of the questions here. But there was a question about dry ice that I don't think was addressed. So has Nigeria leveraged, and this is to Mr. Yakubu, has Nigeria leveraged on dry ice in vaccine cold chain sustainable? Well, I guess are we employing dry ice in cold chain process?
I think for now, not to my knowledge, but we have, for every batch or lot of vaccine coming to Nigeria, we have a temperature monitoring device that right from the manufacturing facility to where it will be delivered here. And again, when NAFDA goes to the port to sample this vaccine, they make sure these things are proper. Again, if we doubt any one of the batches or the consignment, we take this sample to the lab, since we have the lab for potency testing. Then if it meets the criteria or if it passes the testing, then at that point we could release the vaccine. But then if there is any doubt, then we have to hold the vaccine and maybe confiscate it and destroy it. Over.
Okay, thank you very much. I mean, that's as good as it gets, protecting the population from, at the very least, if the vaccines are not harmful, at the very least, they will be ineffective. And so disposing of such vaccines that have been compromised, I think, is an effective strategy to safeguard the health of the nation. I'll also go back to Dr. Bakari Lawal. And this question is with regards to early warning systems. So what early warning systems has technology been able to help us develop in the context of the African experience? Because early warning systems, of course, are important giving us some sort of alert to say that, you know what, this danger is approaching. This is a potential catastrophe in the pipeline. So how has technology helped us to develop more effective early warning systems, especially in the African experience where data might not necessarily be available, or it might be incomplete where it's available or not even documented at all?
All right, thank you very much. So I think I can speak to two body of works that I'm aware of, and maybe a third. So I'll start from the number three, which is something that is around climate prediction. So this has been an ongoing body of work even before we look at the core work we do in healthcare. So with climate prediction, they look at things like temperature modeling. They look at things like hydrological, that looks at water levels and potentially flooding. And they also look at rainfall, among other things. Now, where this type of data meets the work we do in health security is now where we look at the point where weather changes affect disease patterns. So for instance, we already know that wherever there's flooding, you expect to have diseases such as diarrheal disease, just because of overflow or probably sewage systems in places where sewages are still just underground soakaways or septic tanks rather. And then you also have scenarios where if you, okay, so let me just stop at the one that's associated with flooding. So because of that, you have us modeling in disease control for pattern of weather and how we could use that to guide our anticipation of outbreaks and then how we respond. A simple one is for diseases like meningitis, that you know that herd immunity sometimes drops over a period of time just because of immunization, and therefore running this wave every 5 years. So if you look at data, you will see that, so 17, 12, probably somewhere in 2020. I don't think we had in 22, but I think somewhere in 23. But 2017, 2012, I think 2007, you might check that there were spikes of meningitis outbreaks over those period of time. So again, simple process that will just show that, oh, there's this pattern. The other is for weather-related conditions like Lassa fever, which is not necessarily weather, but actually anthropologic pattern around agricultural practices and then rodents. So agricultural practices is wet season and harmattan season related or dry season related in Africa. So you know that during wet season we do farming, and probably toward the end of wet season we start harvesting. The dry season we use sun drying a lot here. And then because of sun drying, you have rodent interaction with the food storages. And then because of that, you will always hear, go and check the data. This period of the year, that's somewhere between end of November to late February every year. 2024, 2023, 2022, 2021, 2020, and keep going back. You will see that that pattern is consistent. So in terms of early warning, some of these things don't even require advanced technologies. They just literally means look at your data and draw up your model. So that's why if you go to a census like NCDC, your logistics teams always do what they call pre-positioning, just based out of those things. And then they will model for the scale of the outbreak year on year and predict based on a few parameters like population dynamics, among other things, for commodities that may be of need in those scenarios. But then we started doing something at Rapid Alert. We started looking at parameters beyond disease-specific parameters, but rather we started going into consumer perception-related data. And then we started modeling them, particularly for the interests of people who travel. And the reason we chose travel, I think I've mentioned it earlier. So we started looking at disease outbreak patterns, vaccine adoption or hesitancy per place. Because if you understand just by literature or just by country data, the coverage of vaccine is sometimes data that is out there. If you go to WHO platform, you might find some of this data. We look at weather patterns, we look at public sector policies, and that might help to make sense of potential for health threats in place. And therefore, if you are willing to go to some of those places, you might be able to anticipate certain conditions. Now, this model is still in the works. We are not gone live with it in terms of public use. Where I'm going to is that in terms of works around predictive models, these are some of the things that we've seen. One of those that we've also worked with is the event-based surveillance system that the NCDC uses. This one is looking at pattern of conversation in the public media and using that to guide potential for health threat. Now, event-based surveillance is everything that is not your indicator-based surveillance. Your indicator-based surveillance is everything that is a number of cases of malaria reported in health facilities. You count that and use IDSR to report it on a weekly basis. Event-based surveillance is looking at everything that might have a health-related implication that has happened in communities, and then looking for how we could pick them and respond to them. So in 2017, myself and a colleague, we wrote a paper on the adoption of event-based practices in communities and states in Nigeria. It was not a practice. And at the moment, I know that if you look at the EOCs that states are building, they currently use some technology that tends to do media listening, looking at what's going on social media, and then probably on traditional media blogs, most of your websites of your media houses. But then this is not exhaustive. Event-based surveillance will still rely on community insight, which is helping community members to know that if you start observing death of animals, if you start observing certain water levels, it might be important for you to notify, because these are precursors to potential health threats or health hazards. And the earlier we report them, the earlier we're able to move on them to say, okay, what is going on? That's investigation. And if there's anything wrong, then we can have response. So I know that the NCDC right now, there's a thing they call the platform Tatafo. Tatafo is one that just looks at what people are saying on social media. It is close to the syndromic surveillance systems that looks at number of patients that are recording fever, number of patients that are recording diarrheal diseases. But this one relies heavily on the adoption of electronic medical records. In a few facilities and health systems that are adopting electronic medical records in the country or in the region, they have the opportunity to aggregate data and start looking at syndromic types of surveillance, which is not necessarily disease condition, but we can say, look, who is recording diarrheal diseases, not cholera, who is recording fever, what's the amount of bleeding. So you can actually define whatever issue of interest you now want to monitor. And that it could be even for non-communicable diseases like number of people with bad limbs. You could go for almost anything just because you might be able to tie that particular scenario to a condition of interest. I think this is where we currently are at the moment. When we had COVID, we were able to model for travel patterns and being able to see what regions of the world were people coming from. So we're able to look at data such as the transmission of the virus in places. And then, so we could say if transmission is much in a county in the US, how many people historically have been coming from that county in the US? Therefore, what is the potential chance of transmission? So that's why during COVID, you would hear kind of selective flight cancellations. You will hear people coming from social countries are not allowed in social parts of the world. That is just part of predictive modeling. But of course, that could become discriminatory because international health regulation is not into allowing you to prevent people from moving. Because if that is the scenario, it could become a wrong practice where I will use exposure to certain conditions to create human rights challenges for people around the world. So I think these are the current situations. I feel there's a lot of opportunities, particularly with the advent of artificial intelligence, to now layer kind of close to what the adaptive concept that Anna spoke about. Adaptive concept allows you to, so we can say with AI, layer data and layer decision making for consumer. And these practices that we are currently testing too within our travel app Safety allows the traveler to almost kind of make sense of what to expect where they are going to. So essentially decentralizing it and giving that to valuable market like travel, to consumers who travel, or to public sector or private sector institutions that deploy people on the field for things like vaccination or even military security. To say, if you have a mission to go and deliver vaccines in the community in Ijebu, there's a platform that looks at historical data and even current situation of data and use historical pattern of that data and what it has used in terms of health outcomes or health conditions to predict potential threats on the way and let the consumer make sense of how to embark on that journey. This is useful at population levels, but like I said earlier, we also are not just building technology for building sake. We feel that modeling for sustainability is key. That's why we picked like the travel space, and then we currently have a partner that we are modeling for mass gatherings. So they bring a lot of people together. Can we use that number of people that gather from time to time to also serve as a case for this? I think these are part of the direction that we are applying and predictive modeling as far as early warning. And let's see how this can go. There are emerging processes in much more complex markets, platform like tomorrow.io, but I don't think the market in Africa is currently as adaptive to those kind of innovation just because of the price points, and they transferring the price point to consumer. It makes them almost tough for businesses to adapt them. But yeah, to the extent we improve the consumer space, I think this will begin to become a thing. That's why poverty alleviation is side-by-side innovation. We can't do one without the other. So these solutions will cost money, and then who will do them? It relies on capital. And that's
I mean, and that's the reality at the end of the day, really, because innovation is not cheap, and innovation really does have to be funded somehow or some way. So getting innovation to a level where it actually can be used by those who are the end users is something that will help innovation to actually move forward more quickly. And that is the hope. And I hope that's certainly a PDALET and every other innovator gets to that point where the end user will be willing to part with their Naira. To make sure
what part of what we are reflecting on is so like the fund here, Solidarity Fund is a fund. So we rely on funds. In the West too, or in the advanced economies, they rely on funds or investment funds. And investors, like I would tell you, this is meant to be public. The kind of capital that came to the revenue, not even capital, that came into Nigeria because of COVID, billions of dollars. This is money that went into private businesses' wallets. And the case, therefore, for this part of the work we are doing is for investors to start reflecting on the potential market cases. So that's part of the reason we are doing this. We cannot be able to convince investors to put money behind some of the concepts just because of how we have to adapt them for the market differently. Yeah,
that's absolutely brilliant. Thank you very much. Unfortunately, we will not be able to take any more questions. Thank you, everyone. It's 4:30. We've come to the end of this session, and it's been such a pleasure being the moderator for this session. And I would like to now hand over to Dr. Fejiro to give us a vote of thanks and round this session up. Thank you, everyone.
Thank you, Dr. Rena. Thank you so much. Before you go, the panelists, please, can you all put on your videos so we can take a snapshot of our panelists? Please just, yes, thank you. Just give us a minute to pin you all so we can have a good, Cyril, are you here? Can you join us? Syria? Please add Anna to the Yes, great. Cyril, are you on? Yakubu, your video, thank you.
I've opened mine.
Okay, great. They'll add you now. Siri, are you
Yeah.
with us? It's just been great. I think that we can. I know Siri is engaged in a conference, so I think we can do with this.
Smile for the camera. Thank you.
Thank you so much. Thank you, our great speakers, panelists. Thank you so much. And special thanks to all of you for gracing this occasion today. Thank you. We've learned a lot from every one of us, and we are definitely encouraged to keep up the good work, do better, innovate, come for funds for those of us that have availability of funds, and then of course make an impact in the health system. So thank you so much. Special thanks to Dr. Banji Filani, the Honorable Commissioner of Health, Ekiti State. We appreciate you for your time and your presence with you, just really giving us insights to the deep dive into what is happening behind the data in the states and a snapshot of the country. Very helpful. Thank you so much. We're very grateful to our participants. You're the reason why we do this. Thank you for staying till the very end. We hope you've learned something. I can see that the chat room has been buzzing. I hope this was very helpful to you. But more importantly, please spread the word. There'll be subsequent fireside chat, roundtable conversations. We'll reach out to you and send you invites when you're ready. Thank you for staying and participating. Lastly, as you exit, there is a poll that you'll be asked to take once you exit. Kindly take the poll. It wouldn't take up to 1 minute of your time. It will help us improve on this webinar. We appreciate you for staying with us. Thank you and have a lovely day.
Bye.
Bye, everyone.
Sorry, we forgot to appreciate Panama Horizon for your support to NSSF on this webinar. Thank you so much. We truly, truly appreciate you. You are last but indeed not the least. Thank you for your support. Have a wonderful day.
Dr. Ayodele Rena. Hey. I dropped off.
Thank you everybody for your time.